Thanks to Endologics for sponsoring this educational program. It's really a thrill and a delight to be with you this evening to talk about this really exciting new technology. I'm delighted to have with me Dr. Tom Maldonado from NYU and Dr. Vince DiGiovanni from Mainline Health in the greater Philly area. Our objectives tonight, we want to talk about current practices and challenges when treating long, complex SFA disease. I'll start off with a brief overview of the PTAB procedure with the DETOUR system. Dr. Maldonado is going to talk to us about patient selection criteria and how to integrate this new technology with your current treatment pathways. And then Vince is going to show us some great cases here at the end. There will be plenty of time for discussion, and we'll pause between each of our talks so that we can engage with you and answer any questions that you have. And then at the end, of course, we're going to have plenty of time to have a far-reaching discussion. So as the token cardiologist in the group, of course, it's always my job to talk about the data. So let me first introduce myself briefly. I started out life as an interventional cardiologist, but my practice is almost exclusively vascular. I'm the director of vascular medicine in the peripheral vascular lab at Miriam Hospital Brown Medical School in Providence, associate professor of medicine. I'm also the director of the vascular medicine fellowship program. And so these are my disclosures. I am on the advisory board for Endologics and was a participant in the DETOUR 2 study as a site principal investigator. So this really is a unique treatment algorithm. We are faced so often with dense, calcified, awful disease, and it's really a bear trying to get through that and retrograde, antegrade access. But sometimes it might just be easier to just avoid that whole mess and simply bypass it. And that's really what DETOUR allows us to do. It's a minimally invasive endovascular option to perform basically a prosthetic FemPop bypass. And I think you'll see in the cases that Vince is going to show that it really does fill a significant gap in our treatment algorithm. So this is a really disruptive technology. The system is designed to provide long-term durability with a minimally invasive approach. Our average length of stay is very short with this procedure. It was 1.1 in the DETOUR study, and it really gets people back on their feet very quickly. So the concept is really pretty simple, basically going from the proximal SFA into the femoral vein, creating an anastomosis, and then going from the vein back into the above-knee popliteal artery, and then advancing a series of stent grafts to basically bypass that nasty disease in order to restore flow to the distal lower extremity. The EndoCross device, I like to call it an Outback on steroids. This is a really ingenious piece of engineering. Unlike the other devices on the market, this is a spring-loaded dual lumen delivery tool. It uses a 0.025 needle, so it is introduced over a 0.014 190 centimeter wire into the proximal SFA, and then there is a over-the-wire lumen in the distal part of the device. So essentially, the first step is to create a pathway from the proximal SFA into the femoral vein, and then that snare, which is waiting in the femoral vein, will just grab and exteriorize that wire, and then the EndoCross device will then make a distal anastomosis from the femoral vein into the above-knee popliteal artery. Now, the torus stent graft is really a unique device. It has considerably more radial strength and crush resistance than the Viabond does. And that's important, especially for the areas where the anastomosis is created. The stent grafts, you'll notice, are uncovered for the proximal 2 millimeters. That's by intention, because we really are going to want to nestle up this device so that we're basically at the floor of the profunda to make sure that the SFA ostium is well covered. We typically are shooting for about 6 centimeters of overlap with the stent grafts. They are available in diameters of 5.5 to 6.7 with 100, 150, and 200 millimeter lengths. and you'll see some great examples of that with Vince in just a minute. This is a slide that we included because I think that you should take a screenshot of this, and your Endologics reps will have this. This is basically all the equipment that you are going to need and should have available in the room. I won't go through the list in the interest of time, but please make sure that you have all of these devices readily available. So the system, again, as I mentioned, proximal SFA into the femoral vein. The ipsilateral posterior tibial vein is accessed with ultrasound guidance. Typically, we deliver a 6 French sheath from the posterior tibial vein, and that snare is advanced into the proximal ipsilateral femoral vein. The endocross device will make a connection, proximal anastomosis from the proximal SFA into the femoral vein. There are markers on the endocross, which I affectionately refer to as the hieroglyphics. And we typically are performing a posterior orientation from the SFA into the recipient femoral vein, snaring and grabbing that wire, then exteriorizing it, and creating a proximal anastomosis, typically with a 4x40 balloon, and then bringing the endocross down into the above knee popliteal artery and simply making another pass from the femoral vein into the above knee popliteal artery. Again, taking a fresh 4O balloon to make the distal anastomosis. Occasionally, you may need to use a 5mm balloon. And then exchanging out for an 035 support catheter, and typically a supercore wire is delivered into the distal tibial vasculature, over which the device, the torus stent grafts, are delivered, and remembering that they are typically delivered through an 8 French up and over approach. So let's talk about the data. So DETOUR 2 was a prospective single-arm multi-center evaluation. There were over 200 patients enrolled at 36 sites, most of them in the United States, with 30 days, 6 months, 12, 24, and 36-month follow-up. One of the strengths of the study, of course, was a dedicated independent duplex core lab, as well as an angiographic core lab, clinical events committee, and a DSMB. The primary safety endpoint was major adverse events at 30 days, including death, TLR, amputation, DVT, PE, and major bleeding. The primary efficacy endpoint was patency at 12 months, as defined by the absence of TLR and a peak systolic velocity ratio of greater than 2.5 within the stent. Most of the patients, about 75%, were Rutherford class 3. The remainder were patients with Rutherford class 4 and 5 disease. To be enrolled in the study, you had to have a long lesion length of at least 20 centimeters. Reference vessels had to be between 4.5 and 6.7 to accommodate the stent grafts, and the SFA had to be accessible at the origin. And as you'll see, you don't need much of a nubbin at the origin of the SFA in order to perform the procedure. A recipient popliteal artery that was patent with a less than 50% stenosis was required, and you had to have at least one patent tibial artery extending down to the foot. Now, importantly, because we are putting stent grafts in the femoral vein, the femoral vein diameter had to be at least 10 millimeters, or there had to be a duplicate femoral vein in order for the patient to be eligible for enrollment. This was the flow diagram, and in the end, modified intention to treat analysis was performed. You can see that there was a very high patient follow-up, over 88% completed 24-month follow-up visits. And if we look at the demographics, most patients were male, 77% were Rutherford 3, but the remainder were 4 and 5. And of course, the usual smattering of high incidence of cardiovascular risk factors, 88% with CAD, very high percentage of smokers, about 60% had had prior PAD interventions. And if we look at CTOs, nearly 100%, 96% were CTOs. Importantly, 17% of the patient cohorts were folks who had had prior SFA ISR. So these were real-world lesions. The average lesion length was really quite long at 327 centimeters. CTO length was about 22 centimeters, and severe calcification was noted in over 70% of these patients. The proximal anastomosis, as you'll find, is usually the quick and easy one. Most of the time, you can get it on the very first try. But now that we are orienting the vein and the artery together, we're having a much more efficient crossing success rates. And typically, during the procedure, it's a minimal amount of blood loss. I will mention that the average fluoro time was about 46 centimeters, and the total procedure time was about 3 hours. Now, you have to remember, we were all in the study as part of our learning curve. And I just did a case last week where literally skin to skin was about an hour and a half. So kind of once you get the steps down, you can move really quite quickly, especially with the crack endologics field team. They're terrific. If we look at the procedural outcomes, 100% technical success rate, very high procedural success rate. Clinical success rate was 96% out to 24 months. And the primary study endpoints were met. Primary patency, which was again defined as freedom from TLR and target lesion stenosis of greater than 50% at 1 year, was about 68%. And freedom from major adverse events, the primary safety endpoint, was 93% in the study. Again, the modified intention to treat primary patency was 72%, again defined as freedom from TLR and target stenosis of greater than 50%. If you use the SVS-derived primary patency rate, it was 81.8% at 1 year and 69% at 2 years. Freedom from TLR was 77% at 2 years, and freedom from occlusion was 87% at 2 years. And freedom from symptomatic DVT was about 96% out to 2 years. Freedom from major adverse limb events, very high at 73.1% out to 24 months. And freedom from major amputation, 98.5%. Again, impressive given the fact that over 20% of the patient population had CLTI. Other relevant secondary endpoints. Look at this really short length of stay, 1.1 days. The rate of PE was 0%. So in conclusion, we saw that the percutaneous transarterial bypass using the DETOUR system creates a percutaneous fempop bypass for these long and complex SFA lesions with a very high procedural success rate. Both the primary safety and efficacy endpoints were met in DETOUR 2. And as I just reviewed with you, very low major adverse and very low long-term venous events. And if we look at the patency, it certainly is comparable to open bypass through 2 years without the need for general anesthesia, with a very short length of stay and a very low risk of complications, and really does provide a standardized, durable technique for these long, complex SFA lesions. So thanks for bearing with me with the data. Again, considering the adverse lesional characteristics, really impressive data, I think. So I'm going to pause there and ask if anyone has any questions about the data. And then it's my pleasure to turn things over to Dr. Maldonado, who's going to talk to us about indications and some tips and tricks with the device. And also we'll talk briefly about reimbursement, which of course is always a hot button topic as well. So if there are no questions, any questions for me?
Yes, sir. I just want to know whether any data on the improvement of the quality of life and the distance where the patient is doing more as a claudicator. Question number one. Question number two is these like 20-30% failures, whether occlusion of the graft or are they dealt with like with thrombolytics left alone? And also these DVTs were the proximal DVTs and the common femoral vein and symptomatic DVTs, or just DVTs detected where the covered stent is there?
I'll answer the last question first with regards to the DVT. One of the lessons learned from DETOUR 1 was that if the femoral vein diameter was protocolized to be 10 millimeters or larger, the incidence of DVT was really very low. So that was actually a mandated criteria for entry into the study. These were patients that of the 7 patients, they were minimally symptomatic, and all 7 of them were able to be successfully treated with anticoagulation alone. They did not require any mechanical thrombectomy or thrombolytic therapy. So that was reassuring that these could be dealt with just simple anticoagulation alone without the need for any invasive intervention. The mode of failure for PTAB, similar to any covered stent or stent graft, is typically related to a very short focal edge restenosis at either the proximal and or distal edge. Most of these patients presented with recurrent claudication. I believe only 1 patient in the study required any operative intervention. Our clinical experience in a couple of cases that we had where when patients presented with a stent graft occlusion, those patients we simply placed an ECOS catheter and then overnight, and then brought them back the next day. And as you might imagine, we saw exactly what you expect to see, namely a focal stenosis that we happened to treat with a cutting balloon and a drug-coated balloon. And those patients have thankfully remained patent since that index repeat intervention.
About symptomatic relief, what did you in comparison to is there any improvement in their claudication time or distance?
Yes, I don't have that data here, but the overwhelming majority of patients, I think, were Rutherford class 0 or class 1. They had, if I remember correctly, the post-procedural ABIs were greater than 0.9. And so they definitely were dramatically improved from a symptomatic standpoint.
Was there a protocolized antiplatelet or anticoagulant paradigm?
Yes, that's a good point. And Vince is going to talk about this during his talk. But per protocol, patients were mandated to be on dual antiplatelet therapy for the duration of the study, which was 36 months. If they needed to be on systemic anticoagulants for other reasons, for example, like a mechanical heart valve or because of AFib, then they were continued on their anticoagulation in addition to the dual antiplatelet. If patients had issues with bruising, then some operators chose to drop the aspirin, but the Plavix was mandated for the duration of the study. Okay, thank you for those questions. I'm going to turn it over to Dr. Maldonado. Tom?
Great. Thanks very much. And, you know, it's going to be very conversational here and going forward at the end. If we have more questions, that's what makes this really a nice webinar, is to have good participation. So thanks for being here. Thank you to Endologics and to my co-speakers here. I've been at NYU. I'm a vascular surgeon, endovascular surgeon my whole life. I've been here, and I've had the privilege of being able to sort of see the evolution of endovascular surgery over the last 25 years, I guess. A lot of arterial, and now exciting that the venous world is catching up too. So I say that because I think that when we talk about patient selection, it's important to look at clinical trials, but to recognize that those clinical trials are done sort of with a rigorous measuring stick, right? We're very, very particular about inclusion criteria and understanding how to keep good patient selection for the trial. And one of the things that can happen, I think, to all of us is we start to kind of push the boundary or push the envelope outside the IFU. So I think what we'll do here is, let me just start by talking about the intended use of the DETOUR system, or the IFU. So it's intended, and the IFU really is for long lesions, 200 to 460 millimeters in length, as we just heard. These are patients who have chronic total occlusions, as you saw in the detour 2, but certainly there are patients who have perhaps a little shorter or some tandem lesions, severe stenosis greater than 70%. And so those are sort of the anatomic sort of broad strokes criteria. But then there's the clinical. Of course, goes without saying, after you see that spring-loaded harpoon, you're not going to use this in the coronary or the cerebrovasculature, but I suppose that's important to point out. What don't you want to use the DETOUR system for? You don't want to use it in patients who have small common femoral arteries. So I think that duplex is important, but certainly serial imaging with a CAT scan is very important. I don't know how many of the listeners or my co-speakers routinely obtain axial imaging prior to peripheral interventions. I know there are many people who don't, who just rely entirely on non-invasive. Well, that's a must here. You really have to have good axial imaging, in particular to look at inflow, but also to understand the diameters of your common femoral artery. As you see, you don't want smaller than 7 millimeters. As far as the clinical DVT or venous history, I think it's very important. I just had a patient I saw yesterday. Unfortunately, I'm going to turn him down because he has this history of distant PE. It wasn't clear if it was provoked or not. Thrombophilia workup's not clear either. So I think you have to have a certain amount of respect for the fact that even though we can position these tourist stents in the venous system, in patients who are prone or who have a history of venous disease, we perhaps want to stay away from those. Untreated flow-limiting aortic occlusive disease, again, axial imaging becomes important there. We want to treat that first up front. The lack of a patent single vessel tibial runoff to the ankle, again, I think that makes good sense. When we talk about patency, you want inflow, outflow, and conduit, and we want to make sure we have good outflow. Coagulopathy, bleeding diathesis, thrombocytopenia, known hypersensitivities or allergies. These are sort of obvious. But these are sort of the indications and contraindications for the DETOUR system. Who would benefit from PTAB? And here's where I think it gets kind of interesting, because certainly we look at patients who would benefit because they have anatomically challenging occlusive disease that's maybe not great for endovascular, maybe heavy calcification, long segment disease. And then there's the clinical, those patients who are maybe poor candidates for open surgical bypasses, people who've had repeated or recurrent failures or reocclusions with endovascular, interventions. I've had one of my patients I did recently had at least 3 or 4 repeat endovascular procedures, and these are patients who I think it makes good sense. I think that when you talk about PTAB and DETOUR, it's important to understand that, in my opinion, and I'd be curious to see what my co-speakers, Peter and Vince, think. You're comparing this not to other endovascular interventions, but really to the above-knee FemPop, right? That's what you're really comparing this procedure to. And so when you think clinically about a patient who would be indicated for a FemPop, that's where this becomes kind of a sort of a counter to that. And certainly there are patients who are not operative candidates. And again, those are great candidates to be considered for PTAB. So how does it fit into your algorithm? Again, going back to the IFU and the clinical trials, I think that any new technology we adopt, and I've seen it in my career, whenever we get a new technology that's fresh out of the gate, we all want to use it, we want to adopt it, we want to offer it to our patients, but I think it's important to stay within the IFU, especially early on, because that's going to give you your best results. That's where you can really rely on the data you just heard about. Those are IFU patients. So patients who have any history of venous disease, who have, veins that are smaller than 10 millimeters or common femoral arteries that are smaller than 7 millimeters, these are patients you don't want to push the envelope on. So anatomically, I think that's a very important point. I would then sort of, by way of just keeping this very open and conversational, I would ask my co-speakers, Peter and Vince, about their algorithm. In my algorithm, as a surgeon who always had that as sort of the equipoise with endovascular, I would offer patients both oftentimes. I think this has kind of broadened my horizons. I'm able now to look at patients who may have medical comorbidities that I'm not eager to perform open surgery on. And I've got a number of patients who actually I've now offered this as an alternative to open surgery, especially the FemPop bypass. I still, like all of us, are relatively new in the real world experience with this technology. So I am very strict about sticking to the IFU we just discussed. But my algorithm anyway is patients who've had repeat failed endovascular treatments with anatomically challenging lesions, with heavy calcification, and who are the other candidate who are not good open surgical candidates. Those are the patients I look to. I don't know, Vince or Peter, do you have any other, pearls about who you would treat with a DETOUR PTAB procedure?
Yeah, I think you've outlined it perfectly, Tom. Actually, it's patients who failed endovascular therapy and really are, you may have a fibrotic lesion, something that's inside of that SFA or that POP system that is resistant to endovascular intervention, and they keep going down. And I think that's a perfect candidate for somebody like this, because that conduit is basically lost. It's no longer something that can be used and relied upon. So this gives you an entirely new pathway. And as surgeons, sorry, we don't mean to gang up on Peter here, but as surgeons, we're always looking at things in terms of, is it a surgical or is it an endovascular, therapy that's ideal for this patient? When we have, we're fortunate enough to be able to offer both of those to the patient. I think this technology kind of fits somewhere in between the two of those, and it really kind of bridges the two of those very, very well. But it's an excellent technology for when you've had failed open therapies and you have a patient who's in, who is basically prohibitive for any type of open surgical or further open surgical procedure.
Yeah, I might just make one quick comment. So patients who've had prior stents, and especially if those are stents that are fractured or displaced, that SFA is lost. You can't go back and try to fix that. The other category of patient, which we're seeing a lot more with the aging of the population and diabetes and CKDs, is we're seeing these just horrific, god-awful coral reef popcorn SFAs that even if you were able to get through it, you'd never be able to get a full expansion of that artery because the depth and the degree of calcification would just prohibit you from getting any kind of meaningful luminal expansion. So in that situation, why, bang your head against the wall? Just go around all that nasty calcium with a PTAB. So that's a kind of case where now that this is available, I'm not going to waste my time. Yeah. That's a case where I would go primarily PTAB right out of the gates.
Yeah. The other interesting thing is we didn't talk too much about this, but you do need by IFU 3 centimeters of sort of running room up front in the SFA. You want 3 centimeters of SFA that's patent. I say that in quotations because it doesn't have to be a pristine, healthy SFA. It can be somewhat diseased, and you can even daughter that SFA and balloon it to create that 3 centimeters to some degree. But you do need that. And I'm as I hear you speak, Peter, I wonder sometimes when we are sort of aggressive endovascularly, I think that one thing we have to be aware of is landing stents flush with the profunda, because you are going to sort of complicate any future PTAB attempt if you kind of jailed that proximal SFA with a stent. If it has to be treated that way, obviously it's treated, but sometimes we're a little bit liberal in where we land our SFA stents, and I think that's a kind of an interesting, problem we're creating now. So,
agreed.
As far as tips and tricks and things like that, there are certainly things that I think we can talk about as Vince gives his case presentations. But I did want to mention one thing, because you're going to hear about the hieroglyphics. You're going to see what Peter referred to as hieroglyphics. I think they call it a flag. And it's Endologics is a very clever way of kind of allowing you to orient that harpoon, that O25 spring-loaded needle, and you want it, obviously you want to know where it's going, but I think that hieroglyphics that directs you can be confusing. I'm just going to say from my standpoint, at times it can. You have to mag up quite a bit, but that's where I think having good axonal imaging, understanding where the relative relation of your femoral artery and vein are to each other, up high in the groin and even down near the knee, comes in handy. I don't know. Do you have any tricks about how you can see that needle as it comes out, Peter?
Yeah, fortunately we have a nice Phillips system, and we just typically will mag up and can usually see the needle fairly easily. And there's no question that magging up is going to really allow you, I think, to really visualize the path that your needle is going to take. Obviously, the hieroglyphics will show you which direction to send the needle forward to, but seeing the needle actually come out itself, I think is very helpful. And just like when you use other needle reentry devices, it's a long 15 millimeter throw. So if the wire doesn't immediately exit, then it's just a matter of taking the tension out and then very, very slowly withdrawing that needle as you're sort of pecking forward. And then typically what you'll see is that the wire just flies through. So I think it's for some operators, they've not seen a reentry device that has such a long throw. So remember that you may have to withdraw the needle as you're trying to advance the wire, because the artery and the vein, of course, are contiguous with one another, and you don't necessarily need 15 millimeters of throw, but boy, it's nice to have it. And that spring loading is really so important for these calcified vessels to have enough ability to kind of pierce that calcium to then be able to make the anastomosis.
Yeah, I mean, be careful with that thing. It is quite a weapon, and if you play around with it off, on the back table, you can inadvertently deploy that thing and harpoon your finger. It's really a very, very active spring that it has. But I agree, by withdrawing it very gently, if you go through and shish kebab the vessel that you're trying to target, you can bring it back into it. It's almost like back walling an artery when you're doing a Seltzer technique, and then gently bring the needle back when you're in the lumen, and then advancing just like that. So it's the same idea. The other thing I just thought I'd bring up, and I'm curious to see how Vince and Peter do this. I tend to like to have a partner of mine with me do these cases. My partner will be on the venous side, maybe doing the venous axis. I'll be on the contralateral or arterial side. But I think it's true that as the learning curve progresses, you get quicker. Having a partner there, I think, especially as you start doing these cases, can really, really help. Not another set of eyes, but also move the case along. I don't know. Do you do them alone, Vince, or?
No, we try to do them all in tandem, and it's made life a lot easier. It's exactly like you said, Tom. Somebody's working on the venous, somebody's working on the arterial. You're getting that 8 French sheath over, and then when you externalize your wire, you've got your rail, and somebody's kind of always holding on that floss wire while you're advancing the devices over the top of things. It's also nice to have another set of eyes on everything. When we do our deployment and our activation of the endocross device, we mag up a lot, and we basically have sidelined the hieroglyphics at this point. We just watch the needle tip, and because the device has got a certain bias, you can tell whether or not you're going to be anterior or posterior. And I look at that with my partner during the case, and that's kind of how we fire everything. But our initial cases, going back to talking about the length of cases, our initial cases when we first started doing these, and they were 3 hour plus cases. As you get more facile with everything and you're comfortable with things and looking at the images and not worrying so much about everything and just kind of moving through the case. I mean, our last case that we did was skin to skin, probably in an hour and 5 or 10 minutes.
Yeah.
So it definitely, there's a steep learning curve, but once you get there, it all makes sense.
Yeah.
Hey, Tom, Dr. Crespo had a quick question.
Yes.
And then Dr. Sheth also had a question. If someone has had their GSV harvested, do you feel comfortable offering PTAB?
Yeah, that's a great question. I think that what I look at very closely is if they have a duplicate system, I'm much more comfortable. And I look at the diameter of the vein. I think that the GSV harvest is not something I've necessarily paid attention to. But I'm very, very particular about the diameter of the vein and hopefully seeing duplicate systems. So I don't know, Dr. Crespo. I have not used that as a relative contraindication, but I suppose it's something to be thinking about.
How are you guys? Thank you for taking your time. I just want to say a couple of things. In my practice, obviously, I'm a vascular surgeon like you, Dr. Maldonado and Vincent. I tend to use the algorithm to try to advance those patients, like you guys said, that have multiple interventions. But I just want to kind of like make a point to try to avoid extending that stent into the P3 segment. It makes a lot of deal for us that we're basically now extending into the below the knee if we have to do a bailout. So just for the listeners, just consider trying to stay in the P1, maybe the stent in the P2, but not try to avoid as much as you can extending that stent into the P3 segment, because then it will basically limit the ability for your vascular surgeon colleague to do a below the knee bypass in case the patient need it. And my question for you guys is, I don't know how many of you guys do DBA, but when we put the stents, are you guys seeing a lot of recirculation of the flow, kind of like at the fistula creation points? I have seen that in some of my cases, and I do a lot of IVUS evaluation, and occasionally I see that the stent is actually in good position. It's not compressed in that location, but I see a lot of recirculation where the contrast gets stagnant prior to the crossing of the fistula when we put the stents. I just wonder if you guys see this a lot or not.
Dr. Crespo, I can tell you that what I think you're seeing is I'll show you an exact image of. And what I think very frequently happens is these patients that we're intervening on have very high peripheral vascular resistance. And it's almost the same as if you were shooting an angiogram immediately post 8 mm PTFE bypass graft to the lower extremities. You get stagnant blood flow just because your peripheral vascular resistance is so high. So what we typically do, so our first couple of cases, I'm stealing a little bit of my own thunder, but our first couple of cases we did, and we shot pictures, and the proximal portion of your bypass looks great, your mid portion looks wonderful, and then your distal portion kind of has stagnant blood flow, and you're like, oh gosh, is there some narrowing that we're missing inside of the distal anastomosis? Is there, poor outflow that we missed or something? We did IVUS, we looked at everything really carefully, and what we found was that there really is there's no problem with the anatomic component to the stent itself. It's basically that your PVR is so incredibly high. So we take some nitro, usually 200 micrograms is more than sufficient. Get a catheter down to the distal end of the stent graft, shoot nitro in, give it 30 seconds, and then shoot a picture mid graft. And you usually see all that stagnant blood flow kind of work its way through, and you'll see your outflow. But I can tell you probably half of my cases, and right now I've done 17 cases. Half of my cases have had that exact appearance, and almost all of them have remained patent.
Yeah.
Despite that concern. So yeah.
Yeah, I tend to, put a little bit of nitro paste on my patients in the pre-holding area just to kind of engorge them and create that vasodilation. Yeah, I have seen it. That obviously, I haven't done as many as you guys you have done, but I have seen it probably now in the three cases, and it always makes me worry. The patients are fine. It's just
Yeah. So we're gonna move along, because I want to make sure we have the hour for Vince. A quick, very, very quick, we can talk about it if we have time at the end. Just comment about reimbursement, because this is something that there's some breakthrough designation that's been afforded to this technology. But something you should know about as far as inpatient versus outpatient. Back in October of last year, we had the NTAP, or the new technology add-on payment, which allowed for inpatient reimbursement through Medicare codes. And then now, more recently in January, we have the transitional pass-through payment, or the TPT, for the outpatient setting. And this has made it more feasible to do these cases as an outpatient. As before, it was really more of an inpatient feasible. This is a 3-year Medicare only program that then will allow Medicare to reassess and assign appropriate payment categories. Here you can see some of the rough numbers. This is sort of a blended average depending on the geography, but you see for the inpatient, it's roughly 32,000 reimbursement with the NTAP code designation, and for the outpatient, 34,000 now with the TPT, which is just fresh from January of this year. So, you can work with the Endologics folks, and they're very, very knowledgeable and helpful about trying to get this through your VAC, your Value Analysis Assessment Committee. And I think that, we can talk more about this if we have time, but I don't want to run out of time here. So maybe what we'll do now is we'll just shift gears, and Vince will kind of bring us home with patient case examples. So Dr. Giovanni.
Great. Thank you very much, Tom. Let me get remote control here. First of all, I'd like to thank Endologics for putting this all together, and I'd like to thank my fellow presenters. It's been a lot of fun actually talking about this and kind of coming up with different ideas about how we're not going to present this to everybody. And let me just see, I'm not getting control. I apologize. It's telling me I don't have control.
While you get that, I just want to tell the audience, I know, Hector, you and I have been in communication. If you do we're putting together a real world experience. So please reach out to me, and we're collecting the real world experience now that DETOUR is wrapped up. So if you're interested, make sure you shoot me an email if you're doing cases.
There we go. All right, great. So that's me. I am a vascular surgeon also. I've been in practice now for, oh, there's a question, cost of equipment per case. I believe it's a bundled package. It's $25,000, Dr. Pillay. I could tell you, and to also to annotate what Tom was talking about, that the reimbursements that we've had thus far in our facility for CMS have all been paid to the tune of $35,000 or $32,000. So we've gotten very, very reasonable reimbursements for all of these. And needless to say, our administration is very happy because these are patients who are not coming back with any type of wound infections. They're not coming back with any type of, exacerbated congestive heart failure because they got too much fluid in the peri-procedural time frame. So they're very, very happy with this. So I've been charged with going over just a run-of-the-mill case, and kind of outlining it a little bit to give a little bit of an idea of how these cases move. As I mentioned, our first couple of cases took us about 3 hours to do, but as we started working in tandem with my partner and myself, we were able to get the case speed significantly improved. And what we ended up finding was that we could go skin to skin in about an hour and a half fairly safely. Actually, the biggest hiccup for us is the distal anastomosis, and I'll kind of elaborate a little bit more on that. So my case presentation will kind of cover a run-of-the-mill case. I'm going to intersperse a little bit of tips and tricks in here, and also some of the helpful hints that we use with regards to moving through these cases. So this patient, just to give you some background, she's a 69-year-old female. She has bilateral lower extremity claudication. She's had multiple interventions to both of her legs for significant multi-level peripheral arterial disease. She's an active smoker. She has a history of hypertension, hyperlipidemia, osteoporosis, and pretty bad peripheral arterial disease. Oh boy. So let me go back. Hopefully this will work. This is our CAT scan. This is our CAT scan from our iliacs down to our tibials. And you can see that there's common femoral disease, but not terrible. She has a flush SFA occlusion. She's got actually a reasonable profunda. Her popliteal comes back at kind of like the P1, P2 segment. And she's got numerous geniculate collaterals, and she's got 3 vessel runoff. Interestingly, despite the fact that she's had multiple interventions, she had never had a stent placed in this lower extremity previously. So that was kind of nice. It's a little bit more difficult when you're trying to tackle someone who's got pre-existing metal inside of there. Not prohibitive by any means, but it's something that makes things a little bit more challenging. Our access points, as you can see, were appreciable. She had a reasonable common femoral artery on the right side. We came up and over. We got venous access into her posterior tibial artery. Some of the patients that we treat will usually have really significantly small tibial veins. So what we'll do is frequently put a tourniquet on the more proximal vessel, but it's really, for us, we found it easiest when we try and access them at the foot and kind of advance things from there, put a 6 French sheath up into the more proximal venous circulation. And then we get our picture. And you can see that this is our picture of the affected side with a sheath in place up and over, and with our snare from the venous side already ready to go. As I mentioned earlier, our orientation, typically, as Pete mentioned earlier with regards to orientation, during the initial DETOUR cases they were being done, they were using a tangential view. What we've found out later on is actually it's a lot easier if you're using an anterior posterior view, and it seems to work a lot better. So what we'll do is we'll shoot a venogram and sometimes we'll shoot a venogram with the purpose of kind of seeing exactly where the endocross device is laying with regards to the vein, and then fire our device. One of the things I wanted to show you was one of the techniques that we typically use, hopefully this plays, is we will put our snare directly adjacent to our endocross device. And when you fire your endocross, what we'll do is we'll actually pull down on our snare. The idea being that if you're through the vein, obviously you're going to have to entrap the snare there. And when you entrap the snare, you basically have got your wire capture. So all you have to do at that point is you advance your snare up to the point of your needle, grab your wire or your needle as much as you can, slowly retract your needle, and then your wire is going to pop directly into the vein, and you can then externalize it. So here you're seeing that it's externalizing the wire here I'm sorry, we're advancing the wire, or I'm sorry, grabbing the wire through the vein. We're getting ready to externalize it. You see we have our grand slam down into our arterial circulation there. And then once you've ballooned that proximal anastomosis, and I think that we're probably going to talk a little bit about that as well if we have time. Once you balloon that proximal anastomosis as aggressively as you can, and you've gotten your endocross device now down into your distal circulation, again, what we try to do is get an anterior posterior view and try to line the two structures up as best we possibly can. That way, when we get our 15 millimeter throw through your endocross device, that you're going to be hopefully shish kebabbing that vessel. And as you walk it back, as Tom mentioned, you should see that wire pass straight into that into that arterial system, and you should be able to advance it fairly distally without any problems. Once you have your wire inside of your arterial segment distally, you bury that wire as far as you possibly can, and then you go to work on really establishing your distal anastomosis. And once you think that you're done ballooning your distal anastomosis, go and balloon it again, because there's a tremendous amount of recoil that's involved in these lesions, and you've got to be very, very aggressive with them. We typically routinely will balloon with the 4 Serenator, and sometimes we'll even go to a 5 Mustang if we need to for these distal anastomoses, because the problem is that you no longer have a floss wire as you're trying to advance your torus device now through your arterial segment. So you've lost your floss, and your only rigid device that you have that's going to maintain any type of purchase in the vessel is going to be your wire. And it can be challenging and difficult to sometimes pass into that distal anastomosis, especially if it's a fibrotic vessel. So once we get our 018, or excuse me, our 014 wire that goes down into our distal circulation, and we've done our initial ballooning, we're going to advance a tandem catheter down into your distal arterial circulation, get a tibial picture, make sure that what you're looking at is in fact, arterial. Ask me how I know that you can get into the venous system and balloon the venous system, because I've done it in the past. Thankfully, there's no long-term sequela, but it can happen. Balloon that. So once you get your 035 wire down in, after you get your tandem catheters down, balloon it again. Use your Mustang balloon and really get very, very, very aggressive with that distal anastomosis. It makes your life so much easier. For the sake of brevity, I'm not going to show you placing the distal torus stents, but suffice to say, you basically go to where your proposed distal landing zone is, which is going to be usually a few centimeters distal to your anastomosis. You begin by building up distally and work your way up, to the point where you're going to be proximal at your proximal anastomosis. Here, you want to get a really, really good magnified view. You want to be absolutely certain that you can see that junction of the profunda and the superficial femoral origin, because it's paramount, as Pete mentioned, that you really land this stent just where you need it to be, which is you need to actually be inside the common femoral artery. Those proximal 2 millimeters of torus stent are uncovered, and they should really be sitting in the distal common femoral artery. If you don't do that, you risk a significant failure on the part of early stent occlusion, if not on table occlusion. Once we've done that, in our practice, what we've come to do is we actually do our, once we finish with our stent proximally, we usually will do an angiogram for the purposes of making sure we didn't jail our profunda, because once you balloon that torus stent, it's very well seated into position. Usually we'll balloon that proximal torus stent with a 7 millimeter, and then the remainder of the torus stents with a 6 millimeter. And going back to what we were talking about earlier, what you will frequently see at times, unfortunately, I didn't have it on here, I apologize. But like I was saying, that you'll frequently see is you'll actually see contrast holdup. And the contrast holdup, as it's going through the stent itself, will usually be situated somewhere near that distal anastomosis. And again, I think I have no science leg to stand on when I say this, but I think it's very likely related to peripheral vascular resistance. And with a little bit of nitro, you see that blood flow go through there much better. Make sure you complete with your venogram. Absolutely certain that you haven't, caused any type of problem that's going to have to, bring you back either that night or the following day. We've had 19 people that we've looked at for this procedure, and 17 we've treated. The only people that we haven't been able to treat thus far, obviously people get excluded early on because of anatomic issues with regards to the arteries. But the 2 people that we looked at early on that we wanted to treat, and unfortunately we're unable to, were people who had previous deep venous thrombosis and had significant abnormalities within their venous system that on CAT scan really didn't look that bad, but we did a duplex and we could see that there was a lot of scarring, there was some webbing. And for that reason alone, we elected not to treat these patients. And I think maybe perhaps somebody that's braver than me will do it and see what the outcome is. But for me, that's something that makes me very nervous. And that was actually one of my initial concerns once I started talking to people about doing these cases, was I was worried about what was going to happen to the vein. And I can tell you that almost of all the people that we treated, with the exception of perhaps one person who ended up not having a deep venous thrombosis, but all of the patients had no significant swelling. They have reperfusion swelling, but nothing that would concern you for deep venous thrombosis. Tom, Pete, do you guys have the same experience with regards to swelling?
Yep.
Yeah.
Usually it's will resolve just with lightweight compression stocking for a week or two, and just have them elevate their legs, and it usually goes away pretty quickly.
Yeah, I mean, I see that just in routine endovascular procedures. Sometimes we'll get some sort of rebound swelling from an increase. There's a question about reason for the venogram, Vince. I have my own reasons for being so particular about that venogram, but why do we do a venogram at the end?
I don't know. I don't know. I don't know. I mean, you should have all the information that you need at the time of your procedure. You know what I mean? When you go in there, from my standpoint, I want to know that I have a minimum of 10 millimeter vein or a duplicate system. And I go in there and I'm like, listen, I know what I'm going to do. And I've seen times when you've had contrast hold up and then you squeeze the calf and things move through it. But what are you going to do if you do a venogram and you see contrast hold up to the point that you're like worried that, okay, this guy's headed for DVT? What are you going to do then?
I personally, and this is where I'd be curious your thoughts, because I've had one patient like that I put on Lovenox, and I know that's not what was done in the trial, but and I know it's not evidence-based in any way, but I was sufficiently concerned, and maybe as I get more experience and I'm not as nervous, because we don't do venograms at the end of arterial cases, right? So for me, that was a reason why I chose to put him on Lovenox. Whether that made a difference, I don't know. There was no DVT, and then I switched him over and took him off the Lovenox on his first visit. But that's my paradigm, or my thought is to look at the venogram. And also, why not? You have the catheter there. I do like to know that there's no clot at the end or any problem.
Yeah. Are you routinely putting patients on Xarelto in the initial postoperative period?
I'm not. But again, this was one where I did put them on Lovenox.
All right.
Yeah, I think if I had occlusive, if I had no flow in the vein, that is a patient, Vince, that I think I probably would say, you know what? We've got the Compass data, we got Voyager PAD, and it might prevent a DVT. What's the harm in a short course of a DOAC?
Yeah.
Agreed. I think it makes sense. We have been routinely putting all of our patients on 10 milligrams of Xarelto, because that was, I guess, magic fairy dust that was coming from some of the initial DETOUR data, and we've actually done very well. The patients have done remarkably well with it. I think that there's value in the venogram, definitely, and I think it's exactly what you guys illustrate. It's that if you have somebody who's got an occlusive device inside of that venous system, and you're worried about, flow being held up, why not put them on anticoagulants? That makes sense. Let me finish off my slides. So I'm just going to show you guys some of the cartoons here with regards to the study. I'm sorry, with regards to the devices. So this is the posterior orientation of the endocross device. As I mentioned again, and this is not by any means poo-pooing endologics, but we kind of have gone away from that hieroglyphics. We do almost always mag up high and just look at the orientation of the needle. We found it's a lot more representative of where everything's going to go. This is a cartoon picture, as Pete's shown. This is just showing it a little bit better of moving the anastomosis from the arterial to the venous. And again, it's not so paramount that you, at that proximal anastomosis, that you're very aggressive, although I would still encourage you to do that. But the distal anastomosis, it's absolutely paramount that you really balloon the heck out of that as much as you're possibly able, because that's when you're going to lose your floss wire and you're going to lose a lot of pushability. You're also pushing through a lot more leg at that point than you are in the proximal anastomosis, and you're a lot further from your 8 French sheath. This is your distal anastomosis and your anterior needle orientation. Again, superimpose those images as best you can. Get your needle throw all the way out and walk your wire back slow while you're probing with, your 014. And you're going to very frequently, especially if you do an orthogonal view, you're going to see that you go right through that vessel through and through. It's just such a far throw of everything. But you know, what's the overall harm in it? I haven't seen any vessel perforations. I haven't seen any type of hematoma, and all these patients are ambulatory 6 hours post procedure with no ecchymosis in their leg. And that's all I have.
There's a question about TPA, if you saw any DVT. I guess I would be worried that maybe in the setting of their arterial anastomosis and sort of controlled rupture with a balloon about giving any TPA. I don't know.
Agree. I think it'd be more comfortable placing them on anticoagulation and seeing how they go.
Yeah.
Yeah, I mean, we do have the data from DETOUR 2 in the 7 patients who did develop DVT. They all resolved just with simple anticoagulation alone. So I think that probably would suffice.
Yeah. The other point I think worth making is that when you do bring these patients into the office and get them sort of a follow-up duplex to sit there with your ultrasonographer and explain to them what's going on, because you're going to get reports of DVT and whatnot, and it's because they're not used to seeing this type of stent in the vein, right?
Yeah, very much so. So procedural practices, you know, best case, things to help your case go as smoothly as possible. We're kind of running out of time, but I'd be happy to kind of talk about some of the things that we talked about. Pete and Tom, also, do you guys want to talk? I mean, I outlined some of those in my last presentation, and basically we advocate for the telescope technique with regards to getting your catheter down in the distal anastomosis. You know, using an 018 inside of an 035. Again, using the anterior posterior view for firing your device, making sure that you have a really good venogram, so you know where you're going to be entering, and arteriogram, excuse me, so you know exactly where you're going to be entering. You know, avoid an area where you've got dense calcium. Make sure you've got good outflow. What else am I missing? I'm sure there's a litany of things I'm forgetting.
One other sort of tip and trick that we had discussed was that with the advancement of the sheath for the venous access in the posterior tibial vein, again, taking a page from our cath lab, where we do most of our coronary interventions from radial access, using a Terumo radial sheath, 6-French radial sheath, is really, really nice for avoiding your sheath getting hung up on the valves. It can be kind of painful trying to get a regular 6-French sheath through the skin into the posterior tibial vein, and a radial, since you're getting access with an 018 wire anyway, if you go in with a 6-French radial sheath like Terumo, for example, it just sails right through those valves. It's very slick. It's very simple. It doesn't hurt the patient. You typically don't have to make an incision in the skin in order to advance the venous sheath. So that's something that we've switched over doing, and it's really been very nice in not having any nuisance bleeding, and it hurts a lot less for the patient. So consider using a 6-French radial sheath for your venous access.
I think I like that, Peter. I'm going to try that. The other thing I think is worth mentioning, I know we're out of time, but it is that one of the key points where you can really kind of burn yourself if you don't establish good purchase with an 014 wire when you do your distal anastomosis. When you get through that endocross into the artery below the knee, you want to really park that 014 wire way down there. And again, that's why you kind of want one vessel open below the knee, because when you exchange after 035, you don't want to lose that 014. So you really want to get good purchase with the 014 down there.
Yeah, one other sort of tip, the distal anastomosis, as Vince alluded to, is probably the most time-consuming part of the procedure, and it does tend to have a lot more recoil than the proximal anastomosis. So, we've sort of learned the hard way that you can balloon it with a 4.0, and then 2 minutes later, you can't get your 035 quick cross. And so cutting balloon and serenader balloons can be really helpful in terms of creating enough room in that distal anastomosis to then be able to deliver your 035 Navi cross or quick cross or whatever your preferred 035 crossing catheter is. All right, there was one question from Dr. Pratzos. Hello, Antonis. How does the DETOUR stent behave through old osteal SFA stents? So, of course, I would be remiss if I didn't say that that is a off-label indication for the device. Certainly not something that I would suggest that you do for your first dozen cases. So in answer, again, it's off-label. People have done it successfully. Jim Joy, who of course is the guy who invented this procedure, has done a number of cases, and it is technically feasible. But again, I think I would really err on the side of trying to avoid that if at all possible.
The reason I ask is because as cardiologists, a lot of times that's the kind of cases that we're going to end up seeing, the failed stents that you mentioned earlier, the restenotic stents. And a lot of times these stents extend to the ostium of the SFA.
Yep, like I said, it has been done successfully, but
Sure.
certainly not anything you want to do while you're getting through your learning curve, I don't think.
Sure.
All right, I think the hour is upon us. I'm going to, as the moderator, take the liberty of wrapping things up. Hopefully you saw tonight that this data for DETOUR is really quite compelling. And these are obviously task D lesions. They're 70% have severe calcification. So for all of those patients who are really very, very high risk for conventional open surgery, for those patients who've had recurrent endovascular failures where they've had displaced stents or recurrent restenosis, those horrible coral reef, mid and distal SFA lesions. I think these are all great cases to think about for PTAB. I would again also remind you to just really try to stick to the on-label indications, at least initially in your practice. The Endologics field sales team is second to none. They're outstanding, and they've done a lot of these cases. They have great tips and tricks and a lot of wisdom. So I would absolutely take advantage of their expertise, and always a good idea to listen to them because they will keep you out of trouble and get your case done very efficiently. On behalf of Tom and Vince, I really want to thank everyone for tuning in tonight. I can't believe, the number of participants we had, some great questions. And this is really just the first of what we hope will be an ongoing discussion with all of you. As people start getting through their initial learning curve, we're going to be talking about more challenging and progressively more difficult cases. So Endologics understands that we want to talk about when things are not perfect and when things go wrong and troubleshooting, and how do we manage patients who have stent graft thrombosis or DVT. So these are going to be cases that hopefully we'll have another discussion on in the not too distant future. So Dora, unless you have any final comments, I think we're probably ready to wrap it up. And again, my sincere thanks to Tom and Vince. Great cases, great discussion, but most importantly to all of you for tuning in this evening.